Hi, and welcome to Chapter 20, Bedside Radiography, Special Conditions and Environments. In this chapter, we're going to be discussing patient care in the radiology department and anything that you may encounter while doing radiography or fluoroscopy. This is including anything that may be inside or outside of the department. So we're going to take a look at some bedside radiography, what intensive care units look like, what important factors should you remember in regards to intensive care units, and any tubes that you may encounter and risk pulling out of your patient while you're doing the exam. So some key terms to remember I have listed, and we're going to take a look mostly at mobile radiography and that C-arm, which is your mobile fluoroscopy unit. So we've been working on some experiments down in lab, pushing that mobile radiography around in the C-arm and how that is set up and moved around as well. I do have a couple videos that I want you to watch. They do a great job of explaining how the C-arm operates and what you need to be aware of when you're operating that piece of equipment. So the ones that are posted are in regards to the OEC, which is what you will see at your sites. Our machine is a bit old, and so the locks are the same, but it doesn't have quite the same movements as what the OECs will have. So I do want you to watch those videos so that you're aware of the different movements and what to do when you get into surgery. So some general terms that you need to be aware of: calling the nursing station before leaving the imaging department unless it's responding to a stat request. If the nurse is available, you want to talk to them about your patient's condition, especially if it's someone you've never radiographed before. So confirm your patient's order in your chart if applicable, so some have that readily available. And then make sure that you're going through your patient assessment. Greet your patient, explain the procedure. Communication is very important. You're going to check that patient's ID band so that it'll be listed along with the birth date to confirm that you're x-raying the correct patient. And then make sure that you inspect and prepare your room for what the conditions are before you bring your x-ray equipment in. So what are those limitations that you have to work around? So there are some things that I want you to think about. If they're in orthopedic traction, so this is a type of device that may lock them in place when you're going into the room. So you're doing some bedside radiography and you're taking a look at that room. What do you need to be aware of, and how are you going to maneuver around that device to obtain those two views that you need to get? And take a look at the size of the room. Are you going to be able to obtain a 72-inch SID when you go into that room, or maybe you're only going to be able to get 56 inches? So being aware of your surroundings is very important when you're going up to those patient rooms. Some special care units that I want you to be aware of: intensive care units and coronary care units are places that very ill patients are going to be placed. So your intensive care unit, these are depending on the size of your institution, it may be subdivided into a medical, surgical, trauma, neonatal, and pediatric unit, and some of them will have separate floors for these units. So just be aware of, it depends on the size of your hospital as to how those units will be set up and operated. The CCU could also be subdivided, but these are primarily patients that are going to be in there for cardiac care. So that's the only thing that they'll be doing in that unit, is somebody who has some type of a heart issue. So most of those, when you walk into the room, they are going to have lots of tubes. There's going to be something placed on their heart to monitor the electrical activity in their cardiac output. They're going to have oxygen tubes placed on them. So you really got to be familiar with the devices and moving those devices out of the way. The most common radiograph that you're going to do up there are chest radiographs. You're going to take the portable exam up and do an AP chest, and then just maneuver around that type of equipment. You can try to shield your patient and provide aprons for anyone who's in there helping you to assist in that situation. We also have a room called PACU. So PACU is going to be a recovery room. This is called your post-anesthesia care unit. So PACU is always going to be located out of surgery so that they can transfer the patient from the OR room into the post-op and PACU rooms, so they're transferred for easy access by the surgeon and anesthesiologist. You will get called up to PACU to do radiographs as well, so sometimes those will be check line placements. You may be doing chest radiographs up there as well, or if they've had some type of orthopedic surgery done, you'll be doing a check for the hardware placement to make sure nothing's moved or changed since they pulled them out of surgery. You have your emergency trauma units, which is your mobile used in the emergency department. These are going to be very critical patients, so you're looking at a lot of trauma. You're going to have to really take a look and assess what needs to be done with your patients. So you're going to be dealing with injuries of the fractures of the extremities. You're going to have spinal cord injuries. You will do lots of chest x-rays in here as well. You may be checking for some line placements. Again, make sure that when you're going in and you're radiographing, especially if you're in the trauma unit, that you provide anyone that's still in that room with a lead apron. So they should have a full lead apron if they have to stay. So sometimes your respiratory therapist has to stay in the room with the patient while you're doing the radiograph. So if they're in there, they should be shielded. And then also remember to use proper protection for you and bodily fluids, because this is the area where you really have to be concerned about that. So make sure you're bagging your DR plates and that you're wiping down your equipment to keep you and the patient safe. Neonatal intensive care units. These are called NICU. These are special units for the care of babies who are premature. They're going to have low birth rate. They're going to have some health issues. We do take the portable into these rooms, and we do chest and abdomen radiographs. So you really need to be cautious of them, especially in an incubator. I will say the nurses are great about helping in these situations. So they'll help you get the tubes out of the way, lines out of the way, place your image receptor underneath. Just remember to keep baby warm. You need to use shielding, so those gloves, those lead-lined gloves, come in great in that situation to cover them up. Okay, so now let's take a look at some of the treatment situations that are going to involve specialty equipment. So in here we do have special beds and mattresses. So this equipment is going to provide continual position or pressure changes for patients. So some of them will have an alternating pressure mattress. They'll have air mattresses. They may have a rocking bed. There may be wave or flotation mattresses that you have to be cautious of if you're putting your image receptor on there. You may have to move beds and have those turned off for mobile exams, and those air beds should be inflated to maximum pressure if you're going into a room with that to take an image. The IR should be placed in front of those that use water or alcohol, and your IMR must be on top of any reflective blankets if they're using those in the department. If you do run across an orthopedic traction, don't change the traction. Ask if your patient's able to move. So it may be, their femur's in traction, but they're able to at least raise the lower portion of their body to allow you to slide the image receptor underneath. If you're not real sure, grab a nurse and have them come in and assist you. So let's take a look at some of the equipment you may encounter. So a tracheotomy is going to be a surgical procedure that has an opening into the trachea. This is going to become a temporary or a permanent artificial airway. So it depends on what's happened to that individual. So the trach is placed through the tracheotomy, and then it's gone into the upper respiratory area. So you may have to provide controlled breathing when you deal with this situation. So you do have to monitor them. They may need suctioning done. So be cautious of that when you're x-raying, so that if they really seem to have a lot of mucus buildup, they may need to have suctioning done. So this is what an example of that trach looks like, and this is where it's placed into the lungs. And then when it's held into place, this is what it's going to look like. So some common insertion sites, you're going to see them placed 5 to 6 into the intercostal space. So laterally and mid-axillary line, it can be as high as the 4th intercostal space and as low as the 8th. So typically it's going to be between 5 and 6. So your tracheal tubes can also be used to deliver oxygen in high concentrations, and they're going to be found in air used for the airway management. So general anesthesia, critical care, ventilator, and an emergency system. So these are your ET tubes. Some places will call them ETT. So these are your endotracheal tubes that they're placing. And this is a nice photo showing you how it gets placed into the patient and where that end stops. Mechanical ventilation, this machine's going to do breathing for your patient. So there's a breathing tube that's passed through the mouth into the trachea. It could be attached to the tracheostomy, and the time exposure has to be made while the machine is doing the respirations. So they look big and scary, but they're going to be pretty easy for you to identify when the patient's breathing for a chest radiograph especially. So this is what that device is going to look like when you walk into the room. Your NG tubes are going to be passed from your nose to your stomach. The NE tubes are passed from the nose to the duodenum. These are going to be used for feeding, decompression, or draining. Sometimes we'll get called up to do an x-ray for the NG tube placement. And a lot of times they're administering medication through these. So you may come across someone that refers to it as an NI tube. It's the same thing as your NG tube. So you do need to watch out for any artifacts, safety pins, holding the tube in place. This is what your tube's going to look like when it's placed into the stomach, and we generally do an abdomen for this. Here's an NE tube. It's going to look like this on your radiograph. We also have devices that are called closed chest drainage systems, so they're used to remove any fluid or air that's accumulated in our pleural space cavity and our lung field. So they consist of a tube placed around the pleural cavity. It's going to be connected to a suction device through a drainage receptacle. When you go in, you need to make sure that that chest is suctioning and drainage is appropriate. You do not disturb that unit. Make sure that you're watching that chest tube so it doesn't get dislodged when positioning the IR for the chest radiograph, and be certain that that drainage unit remains below the patient's level of its chest. When you go in, the one thing, especially if you're sliding your patient back up on the bed, make sure that the tube is free and it's not going to get caught on any railings and pulled out of your patient. So this is how it's inserted. So this is what the device looks like. When it goes in, you're going to see this tube that comes into the pleural cavity, and sometimes they'll place it down here. So we do chest radiographs when we're taking a look at this placement. So this device does sit nicely on the floor, and if it's coming to the department, then they're going to hang it right on the stretcher. Okay. So some lines that you need to be familiar with. They do have intravenous and intra-arterial lines. They're going to have sterile techniques when they're inserting these catheters because they are going into the veins and arteries. They're going to use them for a variety of purposes. So that may be medications that they're placing into these. So they may do blood draws through these. So they're classified as a venous and arterial line. They're going to require imaging to confirm placement and functionality of that line. So you need to be aware of where those lines are. You're going to get called up for a line placement, and then you're going to come into the room and you're going to radiograph that chest exam to make sure that it's in place. So if we're looking at a central venous catheter, which is our CVC triple lumen, it's placed into the vein in the neck, so your internal jugular vein, and your chest subclavian vein or axillary vein, or it could be in the groin or femoral vein if they're having difficulties up there. It's used to administer any medications, again, take out blood, especially if they're looking at the oxygen saturation rates. We're going to go in, we're going to do a chest x-ray to confirm that the line is placed inside that superior vena cava, and in case of insertion through the subclavian vein, so that there's no pneumothorax that's going to be caused by a side effect with that. So this is what that looks like when it's placed incorrectly. PICC lines, they're inserted in the central catheter. You're going to usually see these in the upper line or upper arm. PICC line can be used for antibiotics, pain meds, chemotherapy, if they're drawing blood samples. It could be a single or a multi-lumen line. The tip's going to be in the distal superior vena cava, and they're going to use power injectors on some of the newer PICC lines so that they're automatically injecting meds into the patient. So a lot of times we'll get called up for a chest exam for placement with a PICC line. So this is what it looks like. You'll see multiple lumens. Here's where it gets injected into. So you can see the line down here. It's going to come up here. So it enters, goes into that superior vena cava. And this is what it's going to look like on your patient. So those specialty catheters, they're going to be placed to help monitor and manage critical patients, especially if they're requiring long-term care. So if this is someone who's only coming for a 24-hour stay, they're not going to do these specialty lines. Your special catheters are going to be placed in that pulmonary artery or central veins, your CVCs, your PICC lines. You don't want to disturb those. Sometimes they will do those under C-arm to make sure that they're inserting correctly, and so mobile images are used to verify placement quite a bit in those. So here's a chest x-ray. So this is an AP chest. We can see quite a few things. So here's a tip of a Swan-Ganz catheter. So you'll hear it called the Swan-Ganz, and it's advanced into that right pulmonary artery. Number 2 is where your endotracheal tube came in. Number 3 is a nasogastric tube. Then we have our chest tube, and then there's some monitoring lines from when you go into the room. So sometimes you're coming in and there's more than one thing that's been inserted into your patient. So here's one with the CVC on a PA chest, and here is the venous access port on a chest radiograph. So we do chest x-rays on a lot of patients for line placements. Pacemakers are an electromechanical device that's going to regulate heart rate, providing low levels of electrical stimulation. And these are often inserted under a C-arm guidance as well. And this is what the device looks like inside your patient. And here's where it goes into the heart. And this is what it's going to look like on your radiographs. Thank you, and have a great rest of your week.